Hi, so today's lecture is about how we're gonna treat hyperthyroxanemia and what is hyperthyroxanemia. First, let me talk about that. Anything increase in free T3 or free T4 is hyperthyroxanemia. And remember, it's free. If it's bound, probably that's nothing to worry about because bound T3, T4 do not have an effect. Alright, you to have an effect, over any cell. Alright, thyroid must be T3 free. It should be free, not protein bound. So let me first before dipping into the entire um, drugs part of it, let's just review the physiology. You've taken iodine. Let's say you take salt. All right, your iodide ion comes and it's getting in take by a sodium iodine symporter. But the TSH molecule is really important because this TSH molecule will go and it will actually stimulate this symporter. It will increase the expression of symporters and your iodine will keep coming in. Now, once your iodine is inside, there's this one very important molecule called pendrin. Pendrin, okay. This pendrin, okay, this pendrin is going to go and it's going to lead to uh, the transport of iodine inside the colloid part. All right, this is the colloid part. This is the follicle, thyroid follicle, follicular cell, if I may. Follicular cell is more appropriate. Okay, so the iodine goes and taken in by the pendrin. Next, what do you have? Next, you have this very important molecule. So first step, sodium iodine symporter. Second step, pendrin. Third step, TPO organification. What does TPO mean? So if you can see the one I'm highlighting in purple, this iodine is becoming into iodide. I mean, it's the anionic form is into the molecular form. So it's important, it's done by one arm of the TPO, correct? Then what happens? This is the second step. The fourth step is going to be iodination. And remember, this iodination does not need TPO. As you see, there's nothing of the TPO involved. There are two arms of TPO, that means TPO is going to do two steps. Two but very important steps. Iodination is not one of them. Adding iodine residue, it's enzyme independent, it does not need TPO. Alright, it does not need the TPO. It's just going to go and it's going to bind to the thyroglobulin. Alright, when it binds to the thyroglobulin, uh, the iodine is attached to the thyroglobulin. So obviously you have monoiodine tyrosine or diiodotyrosine. If you look at the thyroglobulin as a molecule, it's made up of tyrosine, and to tyrosine you have an iodine. So that's basically the thyroglobulin molecule for us. All right. Now the fourth step is done. Okay, let's say we've we've done the iodination part of the tyrosine residues on the thyroglobulin. Now the next step is fifth step, which is called coupling. And coupling is done by the very important enzyme again, TPO, thyroperoxidase. As you can see, this molecule is getting coupled to form T3, T4. Now what is coupling? Let me just make it more clear. You've got tyrosine residues. Tyrosine. Iodine, diiodotyrosine. Iodine, single iodine, monoiodotyrosine. If these two get coupled, if these two, the one which I'm highlighting, okay, this one and this one, we form a T3. We form a what? We form a T3. So, if I'm to write it more plainly, a monoiodine tyrosine plus a diiodotyrosine is equal to T3. A diiodotyrosine plus diiodotyrosine is equal to T4. A T4 is converted to T3 by deiodinase because you want to remove one. So this reaction is of utmost importance, and a T4 is converted to RT3, that is a reverse T3, by deiodinase 3, and this is also a very important reaction. We'll see why it's important later, but let me just complete the steps that we have here. The fifth step is coupling, which is also done by TPO. Now the next step is uptake. Obviously here we can see the uptake part of it. Look at the uptake part. We've taken the entire thyroglobulin molecule in the lysosome with the T3 T4 coupled T3 with certain amount of MIT and DIT that is left uncoupled, monoiodine tyrosine and diiodotyrosine. What happens next is that once the reuptake is done, obviously you need to proteolyze this entire molecule, right? You need to make sure that these T3 T4 that are being formed, they are broken off. Let's say we need to cut these so that we have a T3 molecule that is free, and a free T3 molecule is actually what we need. So for that, these lysosomes have a receptor called as thyroglobulin or a thioenol peptidase. Okay, thioenol peptidase. It binds to this receptor. The receptor is going to cause lysis of the thyroglobulin. Okay, having T3, having a T4, having an MIT or a DIT out here as if. And once the lysis is done, okay, let me make lysis by, this is T3 gone, T4 gone, MIT gone, DIT gone. It allows for the release of T3 and T4. So obviously, one thing, it causes proteolysis, and second, it also releases it. What about the MIT and DIT that are left over? Obviously, here you can see in the green that certain MIT and DIT are left over. Okay, sorry, in the green. So those are again reuptake, and it again enters the colloid. So fifth is coupling, sixth is proteolysis and release. Okay, and seventh is an important step that I spoke of out here, that T3 is the most important, right? So you need to do peripheral conversion of T3, of T4 to T3. And to write it down again, T4 to T3 deiodinase 2, very important enzyme. Now let's talk about the drugs. All right, let's directly talk about the drugs, and the drugs we'll do in a color blue. So the first drug that I want to talk about, and I do not go upon the use. I'm not, this drug order is not on how useful a drug is, but it's just on the basis of the entire physiology that we are looking at. Okay, so first we have a sodium iodine symporter inhibitor, and that is thiocyanate. All right. Okay, we have perchlorate. All right, but it's going to block the sodium iodine symporter. Do you prefer it? I mean, we do not use this drug, so we do not use it. Not used. But you can keep that in mind, that thiocyanate is a very important sodium iodine symporter inhibitor. So there's a molecule, I do not know if you know about a sodium nitroprusside, and that's used in a case of hypertension. So sodium nitroprusside has thiocyanate as a metabolite, and thiocyanate could block sodium iodine symporter. So that's a very important point that can be kept in mind, that should be kept in mind actually. Then the second drug we do not have any drug that acts on pendrin. Rather, the pendrin, if it is defective, it can lead to pendrin syndrome, which is goiter and even a sudden neuronal hearing loss, because pendrin is also important in the ear. There's a pendrin protein is a importer. So in the ear, it transports chloride and chlorine, and if pendrin is defective in the inner ear, you will have even SNHL. And if the pendrin is defective in the thyroid itself, you will have a goiter, because your iodine is not being transported, nor the T3 T4 is being produced, and your TSH levels are going to shoot up, and obviously you're going to have a thyroid. That's important to note again. Next is, we have the most important drugs. The most important drugs are the ones that target the TPO. So now, when we target the TPO, we are stopping two reactions. One is, we are stopping this conversion of I minus to I2, correct? And second is that we are also stopping this very important reaction, this very important reaction called coupling. Okay, so two important reactions we are stopping. Okay, and this is really important. Why? Because these are the only drugs that are actually being used. These are the only drugs that we are using for thyroid. And let me actually get into the depths of it. Okay, because this is one drug that needs important discussion. So TPO inhibitors, very high yield. So we've got two TPO inhibitors. Number one is propyl thiouracil, and I'm pretty sure everyone's heard about this drug. It's a very common drug. And second is that you've got carbimazole or a methimazole. Let's speak about that. Now, propyl thiouracil, simple hai. Propyl thiouracil, TPO inhibitor. Does it have any other function? Yes, it is a deiodinase 3 inhibitor too. Sorry, deiodinase 2 inhibitor also. It's a deiodinase 2 inhibitor. So it prevents T4 to T3 conversion as well. So there is less T3. Oh, that's a beautiful drug. But why is this drug risky? First side effect. What are the side effects? Well, hepatotoxic. Really hepatotoxic. Really hepatotoxic. And we are just we know, okay, we know for a matter of fact that it is hepatotoxic. It has its own downfalls, but we use it in a very important case. It is a drug of choice for Graves, hyperthyroidism, hyper T3. It is also the drug of choice if it's hyperthyroidism and the patient is a pregnant woman in first trimester. All right, this is good. Carbimazole or methimazole is also an important drug. It is better when it comes to efficacy because propyl thiouracil is a TD drug and this is an OD drug. That means single dose, and propyl thiouracil is a triple dose. Okay, very important. Second is that the side effects is that it is a teratogenic. So you do not want to give it in first T. First T you don't give. But in second and third T trimester you can give. What does it cause in teratogenicity is simple. It causes cutis aplasia, choanal atresia, and esophageal atresia. All right, that is simple, isn't it? Cutis aplasia, choanal atresia, esophageal atresia. Defect of the face. All right, absence of skin, choanal atresia, defect of the bile, and of the posterior nails, and esophageal atresia. And also it causes cholestatic jaundice. But you can give it in the second and third trimester. This is important to note. All right, beautiful. So it's a good drug. Yes, definitely it's a good drug, and it's given in thyroid storm. But it does not have this addition action of T4 to T3 peripheral conversion inhibition. All right. So then what about it? Well, that's the only thing. That's the only thing which makes propyl thiouracil even compare. It makes propyl thiouracil very important in a thyroid storm. Therefore, it makes propyl thiouracil as the drug of choice for thyroid storm. All right. So therefore, it makes it the drug of choice for thyroid storm. Obviously, there are other side effects from hepatotoxicity, which is like rash, agranulocytosis, then arthralgia, goiter, obviously, graying of hair. Yes, graying of hair is something that we see in patients that come. They say, oh, bhai, the graying of hair has already occurred. What do we do? We say simple, boss, you can't do anything much. You have to take this drug. Otherwise, there was no other option. I mean, you have to save yourself and your hair, obviously. Then we have a very important drug. And this drug is usually forgotten for some reason. People do not really think about this drug. Students. So we've got the one that actually inhibits this thioindole peptidase. The most important is that this is the fastest acting drug. Why? Because it does not. It's just preventing the release of thyroid. It's not decreasing the secretion. For TPO actually decreases the formation. So the preformed thyroid can actually release in a TPO inhibitor. But here the preformed thyroid also cannot release. So it's very quick acting. So this inhibits the release. And we've got two drugs. We've got potassium iodide and lugol iodine, which is almost literally the same. It's just that it decreases the T3, T4. And also also. So it decreases release, plus it decreases vasculogenesis. So the use is simple. Before a thyroid surgery, you want to give it because it decreases vasculogenesis, it decreases the release, it decreases the complications. So it's one of the best drugs that you can give. All right. And also it's fast acting, but tolerance is developed. So potassium iodide slash lugol iodide shows tolerance. Also, it has a side effect because of iodine. It causes dysgeusia, metallic taste, swelling of lips, hypersensitivity react, any hypersensitivity reaction, acne, rhinorrhea, all of these, swelling of eyelids, everything, all any hypersensitive reaction. So again, this is very important. And then the most important drug now that we have is the one that inhibits the deiodinase 2 enzyme. Well, these are the drugs that are used in a thyroid storm. So the first drug that you have is propyl thiouracil. We spoke about it. Second drug that you have is a steroid. Third drug that you have is propranolol. Fourth drug that you have is amiodarone. And fifth is lithium. Well, these two are not used. Obviously, lithium can cause toxicity. So they are not used. The one that is used are the above three: propyl thiouracil, propranolol, and steroid. Especially propranolol, because in a T3, T4, there is going to be excess stimulation. They are going to increase the receptors, beta receptors. So propranolol is also a beta blocker. So it is really important. It can reduce the symptoms of hypothyroidism. That is one. Now we have got a very important medication called radioactive iodine, which is 131. The 123 is actually used for scanning. We've got 125 as well and 131. Now the thing is, 131 causes what? 131 releases a beta particle, and this beta particle destroys the follicle. Follicle destroyed. All right. So when it destroys the follicle, what do we use I-131 for? Well, I-131 is used for hyperthyroidism, primary, obviously, in thyroid adenoma or cancer, mostly cancer. You cannot use it in medullary, obviously, thyroid cancer. Now, what is medullary thyroid cancer? Medullary thyroid cancer is the cancer of parafollicular C cells. So there's calcitonin accumulation, and it gives a apple Congo red birefringence on Congo staining. Also, you can use it in a toxic nodular goiter or a multi-toxic nodular goiter or recurrent graves. Side effect. See, people say that there is hyperthyroidism is permanent. Obviously, hyper T3 is permanent. Also, they say that there can be a secondary cancer of the cervical. And there is an absolute contraindication is pregnancy. Obviously, this is not even something that I need to tell you, because obviously it can cause hypothyroidism congenitally. But definitely it is a very important thing. And the advice you want to give to your patient is that whenever you urinate, you keep your urination you make sure that you dispose it well, because your urine may have the particles. You may have radioactive urine. So that's just one thing that you want to keep in mind. And I think that is about it. You just need to remember TPO is the only drug that you actually use. Other thing, you could use a potassium iodide. And there are two important effects that I want to speak of. One is called the Wolff-Chaikoff effect. Wolff-Chaikoff. What about Wolff-Chaikoff? Simple. You give too much iodine, it blocks release of T3, T4. And there's something called as a Jaws-Basedow effect. Jaws-Basedow effect. It's again simple. It's a hypothyroid gland, hypo T3, hypothyroid gland. It's my mistake, I cannot write hypo T3. There's a hypothyroid gland, you administer iodine or you administer amiodarone, mostly amiodarone. And boom, you'll have increased secretion of T3, T4. And this is a sudden increased secretion of free T3, T4 is called Jaws-Basedow effect. Wolff-Chaikoff, increased iodine, less T3, T4. Jaws-Basedow, hypothyroid gland, put iodine, give amiodarone, increase T3 T4. Simple as that. So we've got this, we've got the drugs, we've got everything done. That's about it. Thank you very much.